Bugün herkese merhabalar, iyi akşamlar. Bugün Castle Health ile beraber Moodist Hastanesi olarak ortak bir webinarda birlikteyiz. Bağımlılıkta mücadelede psikososyal stratejileri
As Moodist
konuşacağız.
and Castle Health, we will be talking about psychosocial interventions in addiction disorder. Our medical director, Professor Kültegin Ögel, will deliver the current status, and then the medical director of Castle Health, Dr. Peter, will share his experience with us. And after the presentations, we might have more questions in order to have an interactive session. Professor, floor is yours. Hello, everyone. But I have a question to Peter and Jeremy. Can you hear the translation? Everything is okay?
I can hear the translation.
Yeah.
Yep.
Bunu paylaşayım size hemen.
O zaman bir paylaşım yetkisi verirseniz
Okay, then if you
paylaşmak istiyorum.
allow me to share screen, I would like to share my
Biraz
presentation.
sözel çevirisi olan bir şey. Ben de orada duruyorum.
Evet, şimdi aldım. Şimdi burada biraz amacımız globalden lokale
Our aim
konuşmak.
here is to
Ama bu
give you a
arada,
perspective from global to local.
birçok konuya da bir şekilde değinmek ve kendi
We will be
kliniklerimizde
touching
neler
upon many
yapıyoruz
different
bunları
topics,
konuşmak.
and I would like to tell you what we are doing in our own clinics.
Türkiye'den, o yüzden
Many of our participants are from Turkey.
McCann
Therefore,
söyledikleri herhalde daha çok ilgilendirecektir. Beni tanıyorlar çünkü en azından.
Peter and
O yüzden
McGill's words are more
ben
interesting to
hızlıca
them because they already know
sunum
me.
yapıp
So I
sözü,
will be rather
Peter'e,
brief, and I'll
bırakmak
give
istiyorum.
more time to Peter.
İlk şeyle başlayacağım. Yani tüm dünyada artık birazcık akım değişiyor.
The
Bağımlılığın
trends are
artık ne
changing
olduğunu
in the world.
görüyoruz.
We see
Bu
that there are
2020
some
çalışması ve
phenotypes
bağımlılıkta
of
3 ayrı
addiction.
fenotipin olduğunu bize gösteriyor.
The Russell's 2023
yani
study
kognitif
shows that there are three
tip,
phenotypes.
diğeri ödül
One of
peşinde
them is
koşan
cognitive
reward
type,
type,
the other
bir
one is
diğeri
reward
rahatlamak
type,
için olan
and the
type.
other one is
Şimdi
relief
aslında
type.
üçü apayrı özellikler içeriyor. Ve
Three
üçü
different
de
types of addictions have quite different
ayrı
characteristics,
yaklaşımlar gerektiriyor. Psikososyal
and they
yaklaşımlar,
require
hatta
different
medikal
psychosocial
yaklaşımlar da gerektiriyor.
approaches or even
Birbirine
medical
baktığınız zaman
approaches
aslında
because
oldukça birbirinden farklı
they are quite
geçişler
different
oluşturuyor. Ve
from each other.
genetikte bir çalışma. Bu çalışmanın
It's
içinde
a
genetik de var.
genetic
Dolayısıyla genetik olarak da farklılıklar olduğunu
is also
görüyoruz.
involved in that.
O yüzden
Therefore,
artık
there are some
sadece
genetic
bağımlılık deyip
differences as well.
geçmek doğru
Therefore, we
bir
cannot simply say
nokta
addiction and
değil.
get on with it.
Bunun
There are different
biraz daha bireyselleştirerek bakmamız
phenotypes.
çok önemli.
We have to
Benim hep gösterdiğim bir
individualize
şey vardır.
that
Bağımlılık
issue. This is something that I show
bağımlılar
in
böyle
my
değiller.
presentations.
Hepsi aynı
Addic-
renkte değil.
Addicted people are not like that. They're
Hepsi
not like the
çok
same.
farklı renkte oluyorlar.
They're in different
Ve
colors. They're quite
bizim
different
bu
from each other.
farklı renklerin farkına varmamız
And we
gerekiyor.
should be aware of
Çünkü
their
hepsini
difference
aynı
and their colors.
terapinin içine
Because
sokmamız
if
çok
we
zor. Çünkü
provide
hepsi
the
için
same
ayrı
therapy to all of
köşelere
them, it will be
gidecekler
rather
ve
challenging because
ayrı
they will all go
terapi
to different
programlarına
corners
ihtiyaç duyacaklar.
and they would probably need
Ve
different
bizim
therapy
de öncelikle
programs.
tabii ki bunu tespit etmemiz ve saptamamız
We have
gerekiyor.
to identify that.
Bu yüzden kapsamlı bir değerlendirme çok önemli hale gelmeye başladı.
Therefore, a
Ve
comprehensive
bunun daha da
assessment
önemli
is
olduğunu
very
görüyorum.
important.
Çünkü araştırmalar da bize bu
Over
yönde
the years, we see the importance of that again and
böyle
again,
olması
and even
gerektiğimizi anlatıyor.
also the
O
studies
yüzden
are showing
gerçekten
us the
tedavinin
same
önemli bir
thing.
parçası olarak
An
görüyorum
important
ben
part of
kapsamlı
treatment
değerlendirmeyi.
is a
Biz kendi
comprehensive
ülkemizde de bunu uyguluyoruz. Ama ben
evaluation.
yıllardır diğer
We
kliniklerde
do
de
that in our
çalıştığım
clinic,
zamanlarda
but
oluşturduğumuz
in
şey
all those
bu
years
çok
that I've been
önemli.
working in different
Mesela
clinics,
Kuni diye
it's
bir
very important.
ölçek oluşturduk.
We have
Aslında kullanım
created a
nedenleri
scale called
buna
Kuni.
benzer ölçekler var. Ama bu biraz
That's
daha
the
klinik bir ölçek.
reasons of
Çünkü
usage index.
buradaki hedefimiz
It's more clinic
kişi
because
hangi
our aim here
alanlarda
is to understand
kullanım
in
nedenleri
what
hangi alanlarda. Şimdi
areas
biliyoruz ki
that the
aslında
person is
kullanım
using.
nedenleriyle bağımlılığı sürdüren nedenler birbirine çok benziyor.
Because the
Örneğin
reasons
rahatlamak
of
için istiyorsa
usage and the
relax
reasons
olma
to
ihtimali gene rahatlamak
continue
için olacak.
the addictions are quite
O
similar.
yüzden
If it is for
Bunları,
relaxation,
saptamak
relapse
ve bunlara yönelik bir program
possibility
geliştirmek,
is higher.
psikososyal tedavi
Therefore,
oluşturmak çok önemli
it is
hale
essential
geliyor.
to identify
O yüzden
those
biz kliniğimizde
factors
bunu
and to
otomatik
create
hale
a
getirdik. Bir
psychosocial
kompüterize
program
halde
accordingly.
arkadaşların hepsi
Now we
uyguluyorlar.
have this a computerized
Tabii şiddet hastalarıyla
assessment
bağımlı
in
ve
our
özellikle
clinic.
kan hastaları
Our
için
colleagues
söylüyorum.
are doing that,
Onların neredeyse
especially for the
tamamı
inpatients.
işaretleniyor. Evet olarak işaretleniyor.
They
Çünkü orada
mark
her şey için
yes
kullanım var. En başta
because
gösterdiğim gibi
there are
oradaki
usages for
kognitif
everything.
type'ta bunların
In the
hepsinin olma
cognitive type,
ihtimali çok yüksek.
it is
Ama daha
most likely
düşük
that all of
ihtimal
them are
verilen
present.
şiddetli
But
bağımlılıklarda
for
bunların dört beş
less
tanesinin işaretlendiğini görüyoruz.
serious addiction,
Aslında bu bize şunu gösteriyor.
there are
Bizim
4 or
bunlarla
5
çalışacağız.
of them are marked.
Herkes
And
için
it is
rahatlamak
showing us
için
which areas that we
yöntem
should
çalışmamız
focus.
gerekmiyor.
So we
Ama
don't have
bazıları
to
için
work
örnek
on the
olarak
relaxation
rahatlamak için
aspect for
kullananlar
everyone.
için onları stresle başa
But
çıkma yöntemi
for
Diğer
but if the
tedavide
person
bunların
is only
hepsini
using for
bize
that,
aslında yol
we have to
gösterecek
teach
bir
him or her
araç
how
olarak
to
görüyoruz.
cope
Biraz
with
daha
stress.
standartize
Therefore,
yaptığımız zaman
this is
işi
helping us to
kolaylaştırıyor belki de o
find
yüzden.
our ways
Gene bizim
in
geliştirdiğimiz
therapy.
bir matrix diyeyim. Aslında
That's
bağımlılığın risk ve ihtiyaçlarını saptamak için
also a
oluşturulmuş bir
matrix that's
matrix.
about
Bu da
to
aslında
identify
bize
the risk and the
iyileşme
needs of the
formülasyonunu
addiction.
hazırlamayı kolaylaştırıyor.
It helps
Konuyu
us to prepare a
konunun nedenini saptadıktan sonra,
healing
temel bir hikaye
formulation.
aldıktan sonra
Once we got the CUNY, once we got the
bize yol
general
gösteren
history
bir
of the patient,
yol
this is
haritası
kind of a
çizen
roadmap
diyeyim. Bir
for
tarafta
us.
tıbbi destek var.
In
Tıbbi
one hand,
destek
there is
ihtiyaçları
medical
neler
support.
olabilir? Sosyal destek
What type of
ihtiyaçları
medical supports are
hangileri
needed?
var,
What type
hangileri
of
yok?
social support?
Hangi riskleri taşıyor?
Whatever type of support
Bilgi almak
he
için,
or she
psiko
has
eğitim
or
için
they lack,
hangi
or
konularda
information
zayıf,
gathering,
hangi konularda güçlü?
in which areas they have enough
Ruhsal destek
knowledge and in
vermek
what
için
others they
hangi
don't.
konularda ihtiyacı var?
For
Örneğin ruhsal sorunlar mı daha
psychological
ağırlıklı, yoksa
support,
kişilik özellikleri mi
which
daha ağırlıklı?
one of them is more dominant,
Aileyle
the
çalışmada
psychological problems
hangi
or the
ailenin
personality
hangi tutumların
traits?
değişmesi gerekiyor?
And the
Bunların
family,
her birini
working with
tek
the
tek
family,
işaretliyoruz.
which
Bir
type of
diğeri
attitudes should
yaşam
change?
düzenini neleri
We work
değiştireceğiz?
on
Tekrarı
each of them, the
önlemek
life
için de nereye dikkat
order,
etmemiz
life
gerekiyor?
arrangements.
Bunu uzun zamandır da
And then
kullanıyoruz.
we
Hastanemizde de kullanıyoruz
have
şu anda
some
ama çok
targets.
2017
We use
yılında
that
oluşturduğumuz
for a
bir
long time in
matrix
our
bu. Ve
hospital,
inanın
and we've been developing that
herkese
since
farklı bir şey. Yani buradaki
2011,
kombinasyonlar
and it is different for each patient.
çok sayıda kombinasyon
The
var ve
results are
bu
quite different for each
kombinasyonlar
patient
her
because there are
bağımlılığı
many
farklı
different
yerlere
combinations
götürüyor.
for each
Bir
addict.
taraftan tabii bunu niye ilk çıktı ortaya? Biraz da
Why we started to use this?
bağımlılık alanında özellikle Türkiye'de çalışanların turnover'ı çok fazla.
There's a
Çok
huge
yeni
turnover
genç
in
arkadaşlar
people
çalışmaya
working with
başlıyorlar.
addiction. We
Onlara
are
yol
having
gösterecekti bir şekilde
quite a
hazır
large number of
standartize
young
bir
people working
sistem
with
oluşturmak
addiction,
istedik.
and we wanted to show them a
Ama
standardized
şunu da
system,
itiraf
a
edeyim,
roadmap. But I should
2017'deki hali bu
confess,
değildi.
this is not how it was
Sürekli değişti.
back
Yeni
in
değişkenler
2017.
işin içine girdi.
We added
Son bir yılda
certain
bir
things, new
değişiklik yok ama
variables have been
muhtemelen yeni
included.
şeyler göreceğiz,
There
yeni
is not so much
ihtiyaçlar,
change
yeni
in the last
riskler
couple of years,
göreceğiz.
but
Yol
probably
haritasını
new
oluştururken de ya da yaşam
needs, new
formülasyonu oluştururken de
risks
yeni
will
şeylerin
be
gelişimine
included
yönelik
as well
çalışacağız.
when
Bu
we are
aslında bir
coming up
taraftan da
with the
birbirimizi
treatment
korumamızı
formulations.
sağlıyor.
This is also
Bir
helping us to
arkadaşla
talk to each other.
konuşurken bir hasta
When I talk to a
tanıtırken
colleague,
aslında
when I'm
nelere
trying to
ihtiyacı olduğunu
talk
böyle bir
about the
akışına
patient,
attığımızda
I can use
karşı
this
daha iyi anladı ya da
matrix
o bana anlattı, ben daha iyi
about the needs
anladım.
of that patient. So
Böylece
we
de
are both in the
bir
same page as two
standart bir
colleagues in order
program
to
uygulama
understand
şansımız
each
daha
other
fazla.
better about this certain patient.
Evet, iyileşme bir yolculuk diyoruz. Bu
Healing
yolculukta en
is a
önemli şeyin bir
journey,
tanesi tabii detoks.
and one of the most
Bir
important
diğeri
thing is
rehabilitasyon.
detox, and the other one is rehabilitation.
Rehabilitasyon olmadan iyileşme olmayacak biliyoruz.
Without
Detoks da çok
rehabilitation, we
önemli.
know that detox is not possible.
Burada
Detox is
tabii
also an
baktığımızda
important
bu arada
factor.
ne var?
What is
Yani
in
detokstan
between
doğrudan rehabilitasyon geçme
detox and
şansımız var mı?
rehabilitation? Do we have a chance to directly move on from detox to
O yüzden biraz
rehabilitation?
daha yolculuğu kafamızda farklı parçalara bölmek çok daha yararlı olacağını
It
düşünüyorum.
will be essential to have different stops on the way.
Bir tanesi hazır olmak. Yani
The
aslında
first of
motivasyon,
them is being
bağımlılıkta en
ready.
önemli şey motivasyon.
Motivation. Motivation
Özellikle
is the most
motivasyon
essential
geliştirmek
things in
burada yine her
addiction.
zaman çok fazla oluyor.
The motivation
Hazır
interviews are
olmayan
very
kişinin
important.
tedaviye girmesi gerçekten
If a
çok
person
büyük
is not
zorluklar
ready,
getiriyor.
and if
Evet, sonra
he or
detoks.
she enters the
İşte
treatment,
bu
there will be a
arada
lot
olması
of
gereken şey stabilizasyon. Genelde
problems.
stabilizasyon çok
Detox,
atlıyoruz.
then
Stabil
comes
olmadan daha
stabilization. We
rehabilitasyona
usually skip
gidiyoruz.
stabilization
Bu
and
da
we want to move on
rehabilitasyondan
with
drop out'ları çok
rehabilitation.
artıran bir faktör
And
olduğunu
it is one
düşünüyorum.
of the main factors of rehabilitation
Çünkü
dropouts.
stabilize olmadan kişi rehabilitasyon aşamasına
Because
geçtiğinde
once persons are in the rehabilitation phase
kurduğumuz o
without
sistem çok hızlıca
stabilization,
bozuluyor.
the system that we
Stabilizasyon
have
aslında
created can
0-3
be
ay arası diyebiliriz.
disturbed
Kimisi
very
için bir
easily.
aydır belki.
Stabilization is a couple of months or 1 month for one person. But without seeing stabilization, directly starting rehabilitation will affect certain things negatively. And the next step is integration. Integration back to society.
Rehabilitasyon olmadan entegre etmeye çalışılan klinikler
People are
görüyoruz.
also confused here. Some clinics are trying to integrate them into society before completion of rehabilitation. And it is an important diminishing factor on the success of treatment. Therefore, this order,
benim kafamda duran bir şey.
the sequencing is something that I keep in the back of my mind. As a hospital, we are more focusing on detox and rehabilitation. But in our Erenköy hospital, also they are implementing rehabilitation actively. Now, institutes should locate themselves well within the system. They should identify in what areas they are good at and in what areas they don't do enough. Therefore, it is essential to bring different institutions together to exchange their experiences, opinions, and knowledge. That's what we do tonight. We are together with our colleagues from Britain, and we have different colleagues in different parts of the world. So
ülkeler arası bir paylaşımda olabilir. Herkes bir tarafı daha iyi yapıyor. Olabilir.
Maybe different countries are well off compared to others in different steps of this journey. We have conducted this study in 2015.
Alkol madde kullananlar, kullanmayanlar, turuncular, alkol madde kullananlar. Ve altta da ruhsal sorunlar var. Hani çeviri için
The
kolaylık
blue ones
olsun
are the
istiyor.
ones who are not
Depresyon,
using
anksiyete, intihar, öfke,
the
dürtüsel,
alcohol and
motivasyon,
substance. The
felaket,
orange ones are the ones which are
antisosyal,
using.
güvensiz davranış.
And underneath there are depression,
Ve
anxiety,
görüyoruz ki alkol madde
suicide,
kullanıcılarında
danger,
bunlar çok
impulsivity,
yüksek. Ben
antisocial
alkolle
behavior.
toplantılarda
As you
şey
see, the
görüyorum.
alcohol users, they have very high
Artık
degrees of those
eskisi gibi
disorders.
mental health ile addiction'ı birbirinden ayırmamaya başladı kimse.
Now people are not
Tamamen
differentiating
ayrı
mental health
kliniklerde
and
ya da üst
addiction.
yönetimler tek bir şeye bakıyordu ama şimdi artık her şeye bakıyor. Çünkü
But now
birçok çalışma bize
the clinics are
ruhsal
looking at
sorunlarla
everything because
bağımlılığın
most
%80
studies
neredeyse
are showing
örtüştüğünü
that
gösteriyor.
mental health problems and addiction has an almost
Bu
80%
tabloda
overlap.
travma yok ama travma da çok önemli bir
Trauma is not included in this
faktör.
table, but also trauma also
Eşlik
is an
eden
important
faktörlerden Ve bu çalışmayı da
comorbid
yeni gördüm. Burada da
accompanying
şey
factors to addiction.
tedavi girişimleri depresyonda,
Here it talks
anksiyeteyle
about
olan
treatment,
bağımlılarda çok daha fazla sayıda.
number of recovery attempts.
Aslında eşlik
You
eden
see
sorunlara
those who have
ulaşmadığımız
addiction have a lot
zaman
of
tedavinin
relapses.
deki başarı oranımız azalıyor. Ve
If you
tekrar
don't
yatışlar
look at the
artmaya
accompanying
başlıyor.
factors, our success rate is decreasing
Yıllar
and
içinde
the
26
relapses are
yıldır
very
bağımlılıkla
common.
çalışmaya başlayalı.
I've been working with
Sürekli
addiction
gördüğüm şey ruhsal sorunu
for
artık
the
atlama
last
olmuş
26
gözüküyor.
years.
O yüzden
Therefore, we should
sadece
not
tek
simply
gözle bağımlılığa
overlook on
baktığımızda
the
hata
mental
yapma payımız çok
health
arttı. Biz de kliniğimizde
area.
hep aynı şeye çok önem veriyoruz. Yani ruhsal eşlik
Therefore,
eden sorun ne?
we are very
İlk
careful in
sorun
our
ne?
clinic about what are the
Ruh
accompanying
bilinçli sorununda.
psychological
Şimdi buna
factors.
arkadaşlar var tabii katılanlar. Şimdi daha iyi anlamış olacaklar.
Probably
Çünkü
my
biz o
colleagues in the hospital
eşlik eden
understand better now
sorunlar,
because
bağımlılık kadar
accompanying
önemsememiz lazım.
factors
Onunla
are as important
birlikte
as the
çalışmamız
addiction
gerekiyor.
itself. We have to work with those things as we work with
Bu
addiction.
yine bizim yaptığımız bir çalışma.
That's another
Bağımlılık
study
profil
that we have
araştırması.
conducted. That's the addiction profile research.
Eğer bir kişi 11 veya daha fazla görüldüğü
If
zaman
a person
temiz kalınan süre artıyor.
has been seen 6 to 11 times of
Yani
psychosocial
bizim çok daha
treatment,
sık
their
görmemiz gerekiyor.
possibility
Şimdi
to
bunu
remain sober
belki
is higher. So we have to see them quite
Peter
often.
veya Jimmy için çok
Probably
belirtecek bir şey değil. Ama
it is not
Türkiye'de
quite
genelde çok
interesting
fazla
for
görmek
Peter and Jimmy, but
çok doğru değilmiş gibi karşılanan bir şey.
in Turkey,
Halbuki
it is
işte
as
gene
if
geldi.
there is an
Gene
impression that
geldi
it
ve
is
gene
not
geldi.
very
Hayır, gene
okay
gelsin,
to see
gene
these
gelsin.
patients again and again.
Çünkü geldikçe
They're
zaten
like,
temiz kalacak.
not him or not her
Bizde
again.
biraz
But
böyle bir
yes, we
kültür
have to
oluşmuş
see
durumda.
them again.
O
Unfortunately, that's the
nedenle
culture in Turkey.
tekrar
It is as
gelmesi
if
hiçbir
a bad
sakınca yok
thing if
için.
they keep
Hatta
coming.
düzenli
It's
gelmesini,
okay
tedavinin
if they
uzamasını çok
come
istiyoruz.
on regular
Türkiye'deki
basis, if we
rakamlarda
can just
gösteriyor.
prolongate
11'den
the
daha fazla
course of
olduğunda
treatment,
temiz
it's
kalma
better.
süresi
Because
çok
if we
daha
see them more than 11
artıyor.
times, the chances
O
of they
yüzden
remain sober is higher.
bizim kendi aramızda kliniğimizdeki en büyük başarı performansı da kişinin ne kadar çok geldiği. Tabii bu genel
Because one of the
sağlık
success criteria
politikaları
that we have
açısından biraz
is
farklı. Çünkü
how
genel
many times
sağlıkta
we see them.
kişinin çok gelmesi sanki
But it
iyileşmediğini
is different from the
gösteriyor.
general health policies, because if certain people are keep
Dolayısıyla
coming and
da çok
coming,
geldi.
it
İşte
is as if the
aslında
treatment is not
sadece
working
sıkıntı
or they're not
ekonomik
healthy.
düşünülür.
Or
Ama şöyle
sometimes
çok
they are
farklı.
thinking that they are having
Bağımlılık
secondary
çok
gains and they are abusing
aslında
the
ne kadar
system.
çok
But addiction is a whole
getirebilirsiniz, o
different
kadar da
story. The
tedavi
more
etme
that you can
şansınız,
bring them
iyileşme
to your
oranınızın
institution
arttıracaktır.
or your clinic,
Bu
you
nedenle
have
temel
higher
hedefimiz
chances for a
her
better
zaman
treatment.
için bizim açımızdan söylüyorum
In
daha
our
çok
point of
getirmek.
view, our main
Online
aim
olabilir,
here
yüz
is
yüze
to make
olabilir,
them come.
grup olabilir,
They can come
yazılı
online,
olabilir,
they can
her ne
come
olursa
face to
olsun
face, they can
çok
join
daha
the
fazla
groups.
getirmeye
We should
çalışıyoruz.
focus more on their coming
Bu da
to
bizim
us.
geçtiğimiz bir ölçek. Bağımlılık seyir indeksi, BASI.
That's another index that we have developed.
Çok az sorudan, 8 sorudan oluşan bir ölçek.
It's quite
Bu
brief, 8
ölçekte seyri,
questions.
outcome'u
In this scale,
değerlendiriyoruz aslında.
we are looking at the course of
Ve bu aslında outcome aynı zamanda hem bağımlı için önemli bir şey. Ben ne
use.
kadar
This
değiştim,
outcome is important for the
terapist
addict
için çok
because they
önemli.
can see
Ben ne
how
kadar değiştim
much
diye.
change they made.
Tamamen
And it
geçerli
is also
bir
important for
ölçek.
therapists.
Ama burada
It
asıl
is
bahsetmek istediğim
a reliable test
maddeyi bırakmak
with
ve
validation.
psikososyal değişim.
Quitting the substance and
Mavi olan
psychosocial change. These are two
BASI'nin
aspects.
içerdiği
The
madde
blue
sorunu.
ones are the article,
Yani
the
madde kullanım
substance
sıklığı.
questions, the frequency
Turuncu
of using
olan
the substance. The
psikososyal
orange
değişim.
one is psychosocial change.
Aslında şunu görüyoruz.
What we see here
Seanslar
is
ilerledikçe
the more
madde
sessions
kullanımı bırakma
the
oranı çok
person
artıyor. Bu
gets,
çok daha fazla.
the ratios of quitting the
Ama
substance is
psikososyal iyileşme
increasing.
çok daha geç oluyor.
But
Neredeyse
psychosocial improvement
2,5-3
comes
kat
much
daha az oluyor.
later. It is 2.5 times
Bu
less
bize
than
tabii yine
quitting
çok
the
önemli bir şey
substance.
veriyor.
It gives us an important lesson.
Detoks tek başına bir şey değil. Bizim
Detox is
arkasında aslında
not
psikososyal değişimi
everything
sağlamamız
on its
lazım.
own. We have to
Ve
create a
bunun üstünde
psychosocial change
durmamız
after
lazım.
that. And we have to
O
focus on
yüzden
these aspects.
bizde birazcık sistem hem medikal hem psikososyal açıdan daha entegre giden bir sistem.
Therefore, we have a more integrated system,
Kısa süreli
medically
kalsa bile
and
hem
psychosocially.
kapsamlı değerlendirme yapmak hem
Even they
psikososyal
stay
açıdan
for shorter
gelişimi sağlamak çok
durations,
önemli bir hedef.
we are having this target to create psychosocial
Evet, ve
interventions as
tedavi
well.
ailenin katılımı. Tabii
The
belki
involvement of family
çalışması da
is
bellidir.
important. Probably Peter
Burada
will
çok
mention that in
batıda
his
nasıl oluyor
speech,
Avrupa'da bilemiyorum ama
that
Türkiye'de
how it
aile
is
çok önemli
happening
bir
in
faktör.
Europe, in the West. But in
Biz
Turkey,
bir şey kullanıyoruz.
family
Yani
is a
bağımlılık
very
aile hastalığı
important factor.
diyoruz.
We
Ve
say that
tedavide
addiction is a
aileyi
family
katmak
disorder.
bizim açımızdan çok önemli.
And involving
O yüzden de
family
çok
is
farklı
essential
yöntemler
for
uygulamaya
us.
çalışıyoruz. Ama
We
bir
are
araştırma
trying to
bizde bize şunu
implement quite
gösteriyor.
different methods.
Aileyle
A research
3
shows
kez
that
görüşme, 3 veya daha fazla kez
seeing the
görüşme
family 3 or more
iyileşmeyi 2,5
times
kat artırıyor.
increases the chances for
Ama
improvement,
bu aynı zamanda
for
şunu demek. Aileyi 1-2
healing
kere
for
görürseniz bir anlamı yok.
2.5 times.
3 veya daha fazla göreceğiz.
You don't.
Gerçekten
It's
aile
not
değiştiği
important
zaman
that you just see them
şey de çok
once. It
artıyor.
is important to
İyileşme
see
şeyi
them
de
at
çok
least 3
artıyor ama
times.
3 veya daha
Because
fazla
when the
kez
family
görmek
change,
gerekiyor. Onun
the
için farklı ekipler
patient
kurulabilir veya
changes.
aynı ekip
You
bunu
might have different
sürdürebilir.
teams, or the
Ama
same
aileyi
team can
sürekli
also
çağırmak, sürekli
talk to
görüşmek
families, calling
bizim
family,
açımızdan,
talk to
bizim
them.
kliniğimizde, bizim
For
çalıştığımız
our clinic,
popülasyonlarda
for the
bence çok önemli
population that we
bir
work
hale
with,
alıyor.
it is quite essential.
Tabii bunun için de gene bir ölçek geliştirdik ve uzun zamandır
We
çalışıyoruz.
have developed a scale
Neredeyse
for that, and we've
6-7
been
bin
working on that for a long time.
bağımlıda uyguladığımızda aslında
And we have
ailelerin kısmi
implemented that
ihtiyaçları da belli bir
6,000-7,000
düzeyde
addicts.
sadeleştirdik diyeyim.
And we have
Çünkü aileyle
simplified the
çalışmak da
risk and the
zormuş.
needs of the
Aileyle
family,
çalışmak dediğimizde
because it
çok
is not
fazla
very
faktörler
easy
var
to
orada.
work with the family. There
O
are
yüzden
multiple factors
10 maddelik bir
involved.
ölçek oluşturduk
Therefore, we have
sonunda
created a scale of
ve
10
bize çok net
articles at
veriyor
the
aslında
end,
bazı
and
şeyleri.
it
Bir
gives
tanesi
us
ailenin
quite
bağımlılara
clear
karşı tutumu.
results. What is the
Bunu değiştirmemiz
attitude
gerekiyor.
of family
Aile içi
towards
bağları artırmamız
addiction? We have to
gerekiyor.
change that.
Ve
In
ebeveynlik
family
becerileri. Bunun içinde de
connections,
3 tane var.
parental
Sorumluluk verme
skills, there
becerisi,
are
kural
3 of
koyma
them,
becerisi ve çalışma
delegating
çözme becerisi.
responsibility, putting rules,
Tabii burada
and
ebeveyn
conflict
derken eş de
resolution
dahil.
skills.
Yani eşler
When we
için aynı şey
say
geçer. Aynı
family, we
ihtiyaçlara
mean
sahip. Çünkü bu çalışma
spouses
için çok
as
önemli.
well. because we've done that study in two different, with the root family and with the spouses. We do this with all families, and we try to clarify what areas we have to intensify our efforts with this family. Because working with the family is quite a comprehensive job, and it is hard to decide where to start.
Bunu Jamie ile konuşmuştuk.
We've discussed that with Jamie.
Popülasyonumuzda eş bağımlılık çok
In
fazla.
our population, co-addictions are also quite common.
Geçtiğimiz bir ölçek eş bağımlılık ölçeği 5F
That's a
dediğimiz
scale
ölçek var.
that we have developed.
5 ayrı faktörden oluşuyor.
It is composed of 5 different factors.
Diğer arkadaş nasıl çevirecek bilmiyorum ama diğer kamlı. Altruizm belki diye
Altruism.
çevirebiliriz.
The first one is
Biri kaygı,
altruism.
biri ses
The second one is
çıkarmamak, görmezden
anxiety,
gelmek, biri kaçınmak,
just ignoring,
bunlardan birisi de
avoiding,
suçluluk duymak.
and guilt.
Şimdi bu 5-6 faktörde ortaya
In these 5
çıkabiliyor eş bağımlılık. Ve eş
sub-factors,
bağımlılıkla çalışmamak
there might be some
suretiyle
co-addicts.
iyileşme oranı
And
çok azalıyor.
if you do not
O
work
yüzden
with
temel
the
hedeflerimizden bir tanesi de
co-addictions,
eş bağımlılığı
it is
yakalayabilmek
also
ve eğer ailede eş
disrupting
bağımlılar
the
varsa
treatment
mümkün olsun.
process.
Çünkü bu doğrudan tedavinin etkinliğini,
Because
başarısına
this
en
is
azından
directly
bizim çalıştığımız popülasyonlarda
affecting the
azaltıyor.
success rate of
Bunun birçok aslında
our
kültürlerde
treatment,
de çok fazla
especially in the
gördüğümüz bir şey.
populations that we work with.
Genelde hani literatüre baktığımızda işte ilgisiz aile vesaire diyoruz ama bir taraftan da aşırı ilgili aile. Yani
There are
eşler
some
bir anlamda
families,
eş bağımlılık
indifferent
ailelerde
families. Some of them are
gerçekten
overly
önemli bir
attentive
sorun.
and
Böyle
developing some
bir grafikte de bunu
co-addiction.
görme
So
şansımız oluyor.
it is
Kırmızılar hangi
also
alanlarda
helpful to
daha
use
yüksek
this
oluyor.
graph
Dolayısıyla bizim
to
hangi
see
alanlarda
if
yani
there are
buradan
any
hangi alanlarda
co-addictions.
üçlü çıkmış.
For instance, in this one, these 3 areas needs our attention.
Son yıllardaki araştırmalar aslında bağımlıların cezadan
According
ya da
to the
kayıptan
researchers in
anlamadığını
recent years,
ama
addicts
kazançtan
do
yani
not really
ödülden çok
understand
daha
about
söylüyor.
the punishment or the
Dolayısıyla
losses,
tüm
but they
servis
understand
programı bazen
more
ona göre
about
değişmeye
rewards.
başladı. Eskiden
Therefore,
böyle
we have to
başladığında
change our
bağımlılar
system
servis programlarında işte
to this direction. When I
bir
first started to work with addiction,
ceza puan tablosu olurdu ve
there was
ceza
a
aldıkça ondan
punishment
sonra da
point
tebrik edilirdi.
tables.
Şimdi tam tersine artık
And if they do not have any
yapmaya
punishments, they were going to be discharged. Now we
ödül
do just the
tablosu kurmaya
opposite.
çalışıyoruz. Tabii
We are
özel
trying to
hastanede
create
bu
reward
çok zor
tables.
oluyor.
It is
Ama
quite
ödül
hard to do
üstünde
that in the private
her
hospital,
bir
but
yaptığı
based on reward,
doğru harekette bir ödül alarak
in
en
all
sonunda
correct
istediği
behaviors
bir ödüle
are
kavuşmak.
given some
Yani
rewards, and
burada
then
artık
they
cezadan söz
get something.
etmiyoruz.
We're not talking
Tamamen
about
ödül
the
üstüne
fines or the
servisteki
punishment
kuralları
anymore.
koymaya
The
çalışıyoruz.
entire rules are based
Özel
on
hastane yürütmek
some
oldukça zor.
rewards. It's hard to run a
İmkanlar daha
private
farklılaşıyor
hospital,
tabii ama sonuçta ödül üstten kurduğumuzda
but
servis
once you have
puanlarının
this
çok daha iyi
reward-based
çalıştığını da
system,
görüyoruz.
service points, it works much
O
better.
yüzden hastanede bizim çok boyutlu tedavi tercih ettiğimiz bir şey.
Therefore, we are
Çıkmış
implementing
programı
multidimensional
standartize bir program
treatment.
tamamen. Ve
We have individual
aslında
healing program.
36
It is a
basamaklı
standardized
basamak değil
program
miydi? Başlıyor
composing
mesela.
of
Yatarken de
36
başlayabiliyor veya
themes,
ayaktan
36
tedavilerle
topics.
yapabiliyoruz.
It can be used
Art
as an
terapi giderek önemli olmaya başladı. Art
inpatient or
terapide
outpatient
gördük.
units.
Özellikle
Art therapy
duyguların
is
ifade
quite
etme
common. I've
konusunda
seen
çok
our art therapists among
işe
our
yaramaya başladı
audience.
ve yattığı
It
dönemler
is
içinde
helping a lot in terms of expressing the
yapmak çok önemli
emotions.
oluyor. Aile çalışmaları gibi bizim olmazsa
Family
olmazımız hem
work
grup
is important that
aile grupları var
we
hem bireysel gruplar var.
certainly involve
Tabii
families.
insanlar hep böyle grup terapi çok sıkılıyorlar. O
Sometimes
yüzden de
people are
öğleden sonra
bored of group
ikinci
therapies.
grupta
Therefore, in
yaptığımız
the
gruplarda daha
afternoon,
çok
in the second
eğlenerek
group, we
öğrenme
are
kısmını kuruyoruz. Mesela
mostly
işte Jenga
focusing
oyunu
on
yapıyoruz.
learning by having
Başka
fun.
oyunlarımız var, hafıza
Playing
oyunları var.
Jenga, we
Bazı
have
temel
different
mesajlar, yine
games,
bağımlılıkla ilgili mesajlar var ama
but we
klasik
have
grup
some
çalışmaları
certain
çok
main
daha akışkan,
messages
biraz daha
about addiction,
eğlenceli
but it
oluyor.
is not like the classical
Özellikle
group
ben yani Türk
activities.
toplumu biraz sıkılıyor çabucak da böyle o
Turkish
terapilerin
society
yapılandırılmış halinden. O yüzden biraz
is
daha
prone to
eğlendirmek
getting bored much
aslında
easily
arkadaşlar
compared to
gelen
others,
şeyler
maybe.
normal
So
grup çalışmalarından çok daha
keeping it a little
fazla
bit fun
etkili oldu.
is helpful.
Psikoeğitim tabii çok önemli hale geldi.
Psychoeducation
Psikoeğitim
is
da çok fazla.
important.
Yani terapiler
There are many
kadar
researches on
psikoeğitim etkili olmuyor.
psychoeducation,
Mesela çok
showing
saçma.
that they are
Tabii
as
ikisi birbirini
effective
tutacak
as the
diye
therapies
düşünmüyorum ben.
themselves. Of course,
O
we
yüzden
cannot
psikoeğitimi
simply say that psychoeducation is enough, the psychotherapy is not
yanında
needed.
terapinin
We
yanında
muhakkak
muhakkak
definitely
koymanın da gerekli
use them
olduğunu düşünüyorum.
in
Tabii
combination.
tek biyolojik tedavilerde uygulanabilir. O yüzden
Of course,
tedavi tek
some
boyutlu
other treatments can be
bırakmaktan ziyade çok
implemented.
boyutlu yapmak
Instead of having a single therapy,
bence
a multi-dimensional
danışanlarımızı
treatment
yakalamak
will
açısından bir yere daha
provide
yakalamazsan çok önemli
much
olur.
better results.
Ama unutmayalım. Değişim zaman ister
But
ve
we should
değişim kolay
remember
olmuyor.
change requires
O
time,
yüzden
and change does not come
bizim
easily.
de çok sabırlı olmamız gerekiyor.
We have to be
Ben
patient.
mesela ilk çocuk ergen servisinde çalışmaya başladığımda
When I first started working
bir
in
yıla
the children
yaklaşık
and the
6 ay
teenagers
sonra ben bir işe yaramıyorum.
department,
Burada hiçbir
after a
faydam
couple
yok.
of
Ben
months,
bu
I said,
alandan
I'm
ayrılayım dedim.
useless here.
Sonra
I
bir
don't
buçuk
create
yıl
any difference. I should leave this space.
sonra hatta ikinci yıl
And
sonra
after 1.5
baktım, ben
year,
bir şey yapamıyorum. Bir
around
şeyler değişiyor. Bir
along the
şeyleri
lines of the
görebiliyorum.
second year, I said, oh, okay,
Bazen
I think I'm
çalışırken de
useful.
çalışan
I
tüm
think I
arkadaşlarımıza
can
önerim
make
o
change. Therefore, that's my
gelişim yaşamak
suggestion
ister.
to
O
our
yüzden benim aileyle
colleagues.
aynı şeyi söylüyorum.
Change
Aile de çok
needs
hızlı beklentisi olduğu için
time. That's what
onlara
we say to
değişimin zaman sürecini
families.
anlatmaya
Because they're
çalışıyoruz.
also expecting a change very quickly, but change
Ama değişim için ne
takes time.
gerekli? Bir, değişimin
But
kişi
what
için
is
önemli
essential for
olması. İki,
change?
değişim için
This change
kişinin
should be important
kendini
for the
yeterli
individual,
hissetmesi.
and
O zaman
first
değişim
people should
söz
feel
konusu olacak.
sufficient
O yüzden
in terms of
değişimin
that
önemliliği
for
ve
this
yeterli
change.
hissetmeye çalışmakta.
When these two come
Değişimi
together,
sağlamak
it is
açısından
important to
çok önemli
create
bir şey.
change.
Tabii çıkmadan önce biz hastanemize geçtiğimiz bir ölçek var. Bunu uyguluyoruz. Moodist Relapse Indeksi diye.
We
Burada
have
ne var?
Moodist Relapse Index.
7 başlık altında relapse
We have
riskinin ne olacağını
7
tahmin etmeye
headings
çalışıyoruz.
in
Çünkü
order
herkesin
to
farklı. Relapse
predict
riski de farklı.
relapse risk,
En başta
because
söylediğim
different people
CSR'den
have
burada
different
bunlar
risks of
geliyor.
relapse.
O yüzden
Therefore,
stres yüzünden relapse
individualization
olma
is
ihtimali var.
important.
Ödül peşinde mi koşuyor? Arkadaş yüzünden mi relapse olma ihtimali var?
The reward or stress
Boşluktan
management or the
dolayı mı relapse olma
friends
riski var? Bunu
or
çıkmadan önce saptayıp
not
ona
having enough
göre
to do.
bir
So we have
tedavi
to
önlemi programı
identify
oluşturmaya
why
çalışıyoruz.
they are
Arkasından da az
using,
önce söz
and
ettiğim
we
hızlı
try to create a program to
bağımlılık
prevent
seyircisini uygulayarak iyileşmede biz
relapse.
nereye kadar gittik? Onu görmeye çalışıyoruz. Burada kırmızı çizgi. Şimdi şöyle aslında bunu şöyle söyleyeyim. Evet bazen basi düşüyor. Yani
Yes,
kişi
sometimes
iyileşiyor. Ama bu
the
iyileşme ne
basi is
kadar
decreasing,
etkili?
person
Bu
is
da o
healed,
kırmızı
but
çizgiyle gördüğümüz bir şey.
that's the red line
Kırmızı çizginin
here.
altına inmesi lazım. Yani aslında bu kırmızı
They
çizgi
should
toplum.
go below red line. Red line
Norm.
is society. That
O
is the
yüzden
norm.
iyileşme bazen çok anlamlı
Therefore,
olmuyor. Gerçekten
sometimes
iyileşmeyi
just
buraya kadar çekebildik mi, çekemedik
getting
mi? Bunu
clean,
izlemek
it is
gerekiyor.
essential that we should drop it much lower.
Evet, bağımlılık gelişebilen ama tekrarlayan bir hastalık diyoruz.
Addiction can be healed, but it can be repeated as well. It can
Evet,
relapse as
kullandı
well.
kişi, sonra bıraktı,
When people use it, they
gene
can
kullandı,
drop,
tekrar
quit it,
bıraktı,
use, and then
kullandı,
quit
bıraktı. Böyle
again,
giden bir süreç.
used and quit.
Bu
That's how
artık
it
dünyada
goes.
da gelişen trend ve benim ve bizim bakış açımız diyeyim biraz daha farklılaşmaya başladı.
But now the trend is
Evet,
changing.
kullandı, sonra
Yes,
bırakma
they use, they
dönemleri
and quit.
artsın, kullanma
We want
dönemleri de
the
daha
durations that they
kısalsın.
quit longer and their usage
Hiç
terms to
kullanmayacak
be
abstinens
shorter.
düşüncesi giderek kayboluyor. Tabii abstinens
Now,
ideal hedef.
abstinence is the
Ama
ideal goal, but
abstinense
now
ulaşamayacak
the
olan
reality
grup
is
için
showing us
gene
that there's a
onları
group
biraz
that will not
bireyselleştirip
reach them. We have to
tedavi ya
individualize
da en
their
azından
situation,
bırakma
and we should
dönemleri
at
uzun
least
olmasına
have
çalışmak çok önemli oluyor.
the clean period, the sober
Bu
periods
noktada
should be as
birazcık
long as possible.
bir 48 saniye müzik çalacağım.
So I will play a music for 48 seconds.
O zaman ilk hedefimiz bence staying alive. Hayatta kalmasını sağlamak. İkinci hedefimiz
Our
terapide
first aim
kalmasını
is
sağlamak.
to make them stay alive.
Ondan
The
sonraki
second
hedefimiz de
target is
hayata
to
katılmasını
let them stay in
sağlamak. O yüzden
therapy, and
hayatta
the next
kalmakla
goal
hayata
is
katılmak
joining the life. Staying alive and
çok
joining
önemli birer
life
faktör. Ama her
are
ikisinin
important
ortasında yer alan da
factors,
bence
but
terapide
in between two,
kalmayı
they should
sağlamak.
stay in therapy.
Aslında buna bir yeniden inşaat süreci olarak bakmak bazen çalışanı kolaylaştırıyor.
Sometimes we
Bakış
have to look
açısını.
at it from as a
Çünkü
reconstruction
muhakkak bir
process,
yerlerde bir eksiklik var ve biz o eksikliği
because
tamamlayacağız. Veya onun
potentially there is
tamamlanmasını
something missing
sağlayacağız.
somewhere.
Ama öncelikle en başta söylediğim gibi eksiklikleri de iyi
But first,
saptamamız lazım.
we have
Daha
to
sonra her
identify
bir
what is
eksikliği
missing.
teker teker
Then one by
tamamlamamız gerekiyor.
one, we have to complete those missing
Ee,
aspects.
Bazen pencereleri unutacağız. Sonra dedik pencereler de eksikmiş diyeceğiz.
Sometimes we'll
Pencereleri
forget the
tamamlayacağız. Ama
windows,
en
and then we
sonunda
will add the
buradaki
windows.
gibi güzel bir ev
But
elde
at the end,
edeceğimizi,
we will come up with a
yeni
nice
bir insan elde
house,
edeceğimizi
a
düşünüyorum.
nice, a new
Evet,
person.
teşekkürler.
Thank you very much.
Hocam teşekkürler.
Thank you very
Çok
much,
keyifli ve kıymetli bir
Professor.
sunumdu.
It's been quite
Aktarımlarınız için çok
enjoying
sağ olun.
to watch
Katkısı
your
olan, sorusu
presentation.
olan var mı?
Now I'm
Doktor
turning to group
Peter'ın
if there are
sunumuna
any
geçmeden önce. En sonunda da
questions or
olabilir tabii.
comments before we
Ama
continue with Dr.
geçmeden
Peter's
özellikle
presentation.
sormak isteyen varsa
We can
buyurun.
have the questions at the very end. Peter?
Thank you. And Professor Ögel, I just wanted to make a few comments. Firstly, to say thank you
Birkaç
for
yorumda bulunmak istiyorum.
fascinating
Öncelikle
talk, really,
çok güzel bir
really
sunum
engaging,
oldu.
and
Çok teşekkür ediyorum.
so
Çok
many
ilgi
points
çekici.
there that really resonated with me. And I mean, the overall impression I'd like to share is how many similarities there are between our treatment approaches and our overall aims and principles. But some of the things that struck me about your approach is how impressively you've grasped the need for a structured, objective approach to individualized care. And that is something which I think we are aspiring to, but still playing catch up with. But I think it sounds like your approach is ahead of many treatment centers, I think, around the world. A couple of other points that you made. So the increased relapse risk that we see with comorbidity, and in some disorders more than others, particularly psychotic disorders, personality disorders, and how there is a need to treat those disorders alongside the addiction at the same time. PTSD is one interesting example where for a long time the consensus was you need to treat the addiction first, then you treat the PTSD. And now we know that actually you really should treat both in some way from the outset. And if that's not intensive EMDR or trauma focused therapy, at least starting with some assessment and grounding skills for those patients. Otherwise, they're going to struggle much more than other patients, and probably find it harder to get through a period of inpatient treatment. And so there are a couple of other interesting points there. I liked what you said about getting bored easily being a Turkish problem, maybe, but I have to say it's everywhere, at least everywhere that I've worked, and certainly Ireland and the UK and America. And I often tell patients when they bring it up, because where we're located, we're out in the middle of the Scottish countryside, and after groups and activities are over, there's not a whole lot to do. And so I tell patients that really it's a core part of the treatment for them to be able to experience boredom and to be able to deal with that emotion without reacting in some way. And we have other strategies for helping patients deal with that. But I did think that was an interesting point. So shall I just get on and do my presentation now? Let me share my screen.
Of course, sure, of course.
Okay, can everyone see that?
Yes, we can.
Okay, great. And let me just move the bar out the way. Hang on, I need to actually go back to the beginning. Okay, so thank you again, Professor Ögel. Thank you everyone for joining, and Ayşe and Jamie for setting this up. My name is Dr. Peter McCann. I'm the medical director at Castle Craig Hospital, which is part of the Castle Health Group. Castle Craig Hospital is based in the Scottish borders. I'll talk a bit more about Castle Craig later. There is another inpatient unit located in Ireland called Smarmore Hospital, Smarmore Clinic. And then Jamie is the outpatient director who runs Catch, which is the It's one of the outpatient services, which is based in London and runs teletherapy groups and individual therapy for patients with addiction disorders. We also have links with the Netherlands, and we have a clinic in Sweden called SBK. So this is a picture of Castle Craig. And so just to start off by saying I have a salary with Castle Craig. I'm also a board member, but don't receive dividends or shares. So those are my only kind of conflicts or disclosures. I threw in a few learning objectives, but don't worry, I'm not going to test anyone on them at the end. But I'm going to just cover broadly what I'm talking about by psychosocial interventions, why they're important. I'm going to focus on 12-step facilitation therapy and talk about it in the context of psychosocial interventions, because that is the core part of our treatment program. Although more so in recent years, it's been joined by other modalities, other therapeutic modalities, as their effectiveness has come to light. And I should also start by saying really that the psychosocial part of our treatment is really just part of the biopsychosocial approach that we take, and medical interventions have always been a core part of our treatment program. I'll talk about the social context in recovery, the role of the environment and family, and how we manage that. And I'll touch briefly on what I think about the global context here, and the need for cultural adaptation in places. So I just wanted to start just very briefly. I'm going to just share this slide, which looks at age standardized deaths attributable to alcohol. And it's a little bit different from the non-age standardized deaths, which in some of these countries, including Turkey, and some of the West African countries, looks a lot more normal. But when you age standardize it, you see that actually there are higher rates of alcohol-related deaths. So it's an important point that alcohol does actually, it kills people at a younger age, in a younger age group, than other diseases like heart disease and cancer. So Turkey here, falls somewhere on the lower end of the scale, but not, still a certain number of alcohol-related deaths, less so than the UK and Ireland. Russia's an example of one of the worst affected countries. And the next slide is, it's a little bit messy and small, but I just wanted to again show here the difference between this is disability adjusted life years, and the top graph, the top map shows alcohol, and the bottom shows attributable to drug use. So it's interesting just to note, in terms of the global and cultural relevance here, that of course countries that have a majority Muslim population do tend to have, or at least report, lower rates of DALYs attributable to alcohol. But that effect disappears when you're looking at drug use, but compared to Western countries like, well, the UK, for example, the UK does badly in both categories. So it is, these are global problems. This is a global disease, but the distribution does change depending on countries and cultural and social impacts. So just to run through what I'm talking about with psychosocial interventions, the first thing I wanted to say about them is that we know they're important, and one of the reasons we can say that for sure is that we have international guidelines that recommend them, and I was looking through a few of these yesterday to remind myself of how many of them talk about them, and it's really just about every notable guideline now makes specific mention and incorporates psychosocial interventions alongside medication management or on their own. And I was surprised to see actually that most of these guidelines also recommended that these be provided in integrated settings, right, where patients have access to psychiatric, psychological, and social services. And I was surprised because in the UK, that's absolutely not the case. In terms of the majority of service provision for patients through the NHS, they don't receive anything like an integrated service. When they do get access to drug and alcohol services, they have access usually to a nurse who's the key worker, and they have occasional access to an addiction psychiatrist. But that's about it. They do have access to psychological services in some settings, but it's very restricted. And they usually have a policy, the psychologists in the UK, of saying, well, if they're actively using, we can't really see them because they won't turn up to appointments. They won't be able to take anything in, and really, in my mind, that's a huge part of the stigma associated with addiction, and it's a shame for me to see that in the country I live in. So when talking about these interventions, I see them either as distinct with psychological interventions on their own and social interventions on their own, or interventions that combine the two, such as family therapy, 12-step facilitation, like I see as one that combines the two, and contingency management. Just running these are some of the guidelines that I was referring to before, so I won't go into any detail as I've already talked about them. But I did manage to look up the Turkish Ministry of Health, which and I used Google Translate, so forgive me if I got any of this wrong. But I believe it's called the Guide to Fighting Addiction, and this guideline also refers to the need for combining medical, psychiatric, social services, and providing group therapy and family therapy to bring about holistic recovery. And they also emphasize the need for treating co-occurring disorders, which, as we just heard, is incredibly important. So I'm going to move on now and talk a bit about 12-step facilitation therapy, which, as I mentioned, is a core, the core part of the treatment model that we use at Castle Health. And just briefly, for those who are unfamiliar with it, because it's not used everywhere, and it's certainly, it was never, for me, it was never taught in the medical syllabus or even with psychiatric training. The 12-step principles, the 12-step approach. So it's 12-step facilitation describes a structured approach to using the 12-step principles to increase engagement with 12-step meetings, 12-step groups. And the 12-step principles themselves have, if you break them down, three very broad aims of bringing about a state of acceptance about the illness for the patient, bringing about a state of willingness, also called surrender, a willingness to accept help, to accept change, and then the third component being fellowship, which in the case of 12-step model is achieved through attending meetings regularly, and other parts of it, such as outreach and providing sponsorship and involvement in organizing groups, etc. The long-term aim of 12-step facilitation therapy, therefore, is to bring about this active engagement in 12-step groups, and really we've known for a long time anecdotally that this is an effective form of treatment for many people, and more recently in 2020 there was Dr. Kelly performed a meta-analysis comparing 12-step facilitation to CBT and other treatment approaches, and he found increased abstinence not just at 12 months, but continuing into 24 months and 36 months. And it's an impressive finding in itself. It's enough to, I think, justify the use of 12-step facilitation in treatment centers, in outpatient clinics, and yet it does still remain, I think, outside of rehabilitation hospitals and clinics, it remains a bit of a fringe approach to treating addiction. So at least in the UK, you don't see it used in NHS addiction clinics. They'll take a CBT approach, which can be fine. And for many people, there are barriers or blocks to people engaging with a 12-step approach, particularly in more secular countries like the UK. There are people, I had one patient today actually who just could not get around the references to a higher power and God. And despite there being quite a lot of work that the 12-step organizations have made to facilitate or to enhance openness to people who don't belong to a denomination or a particular religious belief. It still can be a barrier for some people, and then CBT approaches are obviously a better choice. I just wanted to briefly talk about this interesting study I found, which I was researching. I was trying to find studies that showed some kind of neuroscientific basis for how rewarding I hear patients tell me engaging in these groups and 12-step meetings is. Often I'm amazed by seeing patients come into Castle Craig going through withdrawal, having low mood, anxiety, but getting very quickly integrated into the groups and having to share about themselves very quickly, and then seeing them afterwards and seeing fairly quickly the lifting in their mood, anxiety seeming to improve, rapidly, and so this study shows that when people are talking about themselves, they have increased activation of the nucleus accumbens and reward circuitry in general compared to when they're talking about other people. On the left side, A shows when they're sharing their opinions, and then B shows beliefs. They're sharing beliefs about themselves. Similarly, they looked at introspection, thinking about the self, thinking about oneself and one's role in the world, and then disclosing that information to others. And again, finding activation of the nucleus accumbens more so in those people who were thinking about themselves and sharing that information with others. So it's nice to see at least some kind of scientific basis for why patients who manage to get into this this type of treatment and start going to groups can rapidly become integrated into it and use it as a base to bring about quite profound change in their lives. So to just talk a bit more about Castle Craig Hospital in particular, it's an 82 bed inpatient unit close to Edinburgh in Scotland, and Castle Craig has a full medical service with 24-hour nursing, 24/7 on-call medical doctor, on-call psychiatrist who's there 5 days a week and on-call the rest of the time. And then the core of the clinical staff really is the therapists who are all trained in 12-step facilitation, and then many of them have additional training in CBT, cognitive behavioral therapy, dialectic behavioral therapy, trauma, either trauma-focused CBT or EMDR, and then some of them have additional training in managing eating disorders. And one of our therapists just completed training in managing menopause, symptoms related to menopause. So they have a variety, range of therapeutic modalities they're trained in, and the need for this, we recognized really over the last 10, 15 years, how much more we were being presented with patients who had significant comorbidity and who were asking for help, were seeking out help for that, specifically, not coming just for the addiction treatment, but because they recognized that they were crippled by severe anxiety or depression. There are also gym exercise facilities on site and a number of alternative therapies as well. The core of the treatment program is 4 weeks of 12-step facilitation focused centered program, and then all patients when they come in have so all patients undergo medical and psychiatric assessments and complete a range of psychometric scales to assess the degree of alcohol dependence, additional drug use, or primary drug dependence, to screen for eating disorders, gambling disorder, and a scale to look at self-esteem and trauma. So all of that information is brought by the therapist, the focal therapist for the patient, along with the biopsychosocial assessment, which is a comprehensive assessment that they carry out with the patient over 2 sessions. And the results, or the assessment from that, is discussed as a whole clinical team at one of our weekly ward rounds, and that's always an important opportunity to share as a team what we, with the focal therapist leading the discussion, what the treatment plan should be, and then other team members joining in with ideas they have, and a chance to ask questions that the focal therapist may have missed or already thought about, and a chance for us all to hone the treatment plan and make it a truly individualized and effective plan. And then the daily schedule here, this is a brief rundown of it, but essentially when patients wake up at around 7, they have a morning reflection session or meditation. then they have breakfast, and then they have a psychoeducational lecture every single day, which follows a different theme for each day of the week, and runs over 4 weeks, so that all of the material is covered. They then have group therapy sessions, which is a core part of the treatment. And then they have time for individual sessions. In the afternoon, they'll do a workshop where they reflect more on what they learned in the morning lecture. And then there's time for gym and recreation activities, and then an evening reflection. And then there are specialist groups that, depending on the patient's assessment, they can be referred to trauma group, grief, ACOA, adult children of alcoholics, but it includes adult children of any addiction disorders, and also groups for eating disorders, menopause, and executive functioning issues. So primarily ADHD, which we see a huge amount of. So the medical team, myself, the therapists, and even the housekeeping staff, the kitchen staff, we all work very closely together and communicate on a daily basis at our clinical meetings, and then more intensively at the weekly MDT meetings to plan and tailor the individualized treatment for our patients. So moving on, I wanted to just talk a little bit about the social interventions that we use and that are effective and used more generally in the United Kingdom. And I've classed them according to, well, in the first instance, the initial aim of our first contact with patients is to bring about a destigmatizing effect, to reduce the stigma associated with the disease, because we've found the importance of that in terms of increasing engagement and keeping patients coming back, as you talked about earlier, Professor Ögel. That coming back effect, I think a key part of it is that actually, patients are feeling like they're feeling accepted and able to actually to come and get help for their problems for the first time, probably in a long time. And so all of our help center staff and admissions staff are trained in trauma-informed care and in how to approach people with addiction disorders in a non-judgmental way to reduce the feeling of stigma and shame. And we tailor all our information on our websites to achieve that effect as well. The other important approach in the social intervention category that's really a core part of our treatment is direct family involvement. And this is something that we have tried to integrate into our health system throughout the course of treatment, right from the pre-admission phase through to continuing care and outpatient. And so an example of this, early in treatment, all family members who we have consent for are asked to share an impact letter, which can be a hugely therapeutically helpful intervention, especially for patients who are still ambivalent or are unsure about whether they truly need to follow that path, whether, for a lot of patients who've come in as a kind of emergency, something terrible has happened, they've had an accident or done something which has caused a lot of embarrassment to the family, and in that moment they've hit rock bottom and they agreed to come into treatment. And within the first week, for a certain number of our patients, I see this, that there can be a big drop off in that motivation and that acceptance. So this can be a really helpful intervention to act as a reminder and a chance for the family as well, while the patient is in a controlled and safe environment, to really share with them the impact that the behavior they've shown in their addiction has had on the family and on them. And then all patients are offered family therapy, and for a lot of people this might only take the form of 1 or 2 sessions, but where it's indicated, we will continue that after discharge. And there are quite a few families who take us up on that. And then for me and the therapists, we really often, even before treatment, for more complex patients, will be involved with their local key workers, if they have them, alcohol and drug teams, social workers, housing support workers. And we try to get that engagement going very early on, knowing that even those more complex NHS patients who we treat, who sometimes come for 3 or 4 months, that time can go very quickly. And the situation we're always striving to avoid is having somebody who has come from a chaotic, a difficult environment, where there's lots of cues and triggers for drug or alcohol use, to have to go back there after successfully completing a course of treatment with us. And so when people are coming from those kind of environments, we work incredibly hard to find ways to ensure that the environment they're returning to is as stable as possible. Just briefly to talk about the idea of 12-step facilitation itself as a social intervention. I see it as such in the sense that it can be an incredibly powerful tool for reducing stigma, and it's this engagement with peers. It's a peer-led approach. The mutual support groups, AA and NACA, etc., they're all peer-led, and one thing that all patients say is that they feel this sense of acceptance right from the outset, which massively reduces this internalized shame, and I think it's a huge part of why we see people go back again and again and manage to use that to continue their recovery. They also see other people going through different stages of the cycle of addiction. They see relapse happen, and they see remission happen. They see what to do when someone relapses, and so the stigma of relapse itself can be reduced through this. And I've seen just in the last few years the idea of peer support services as an important intervention in other areas of psychiatric care, and the NHS in England in particular is very interested in using those more, and there are good reasons for it. And 12-step groups, mutual support groups, they have this really built into them through the sponsor system and just the way the groups are set up. TSF, so as part of that, it promotes a new identity for people in addiction, a shift from being an addict or someone in addiction to being someone in recovery, and that can be very powerful for someone who's seen themselves as someone in addiction for many years. And then there's a huge community engagement aspect to 12-step facilitation. The step 12 reads, having had a spiritual awakening as the result of these steps, we try to carry this message to alcoholics and to practice these principles in all our affairs. And continued social engagement is really, it's the final step there, and it's the step that I think brings a lot of fulfillment to people who engage in this treatment. There are challenges, of course, in particular around adapting this model of treatment to other cultures. As I mentioned earlier, probably, one of the biggest barriers that I've come across has been for people who are atheists or agnostic, who struggle with the idea and the terminology, and the thing to say about that is it is an adaptable treatment model, and probably the way that it's set up as an organization, or the way the different groups are set up as organizations, allows for flexibility, as there's no real top-down administrative structure to it. And so the 12-step groups, they did originate in the US, as did almost every major kind of psychotherapeutic modality, interestingly. And I'd say, all of these different interventions, CBT, DBT, MI, MBT, they've all been successfully adapted to non-Western societies and cultures, and so have 12-step groups. Probably because they hold at the core of them a mission to help people with addiction disorders to find recovery, and that core mission enables people to see ways around the differences that might arise. And I think as treatment providers, we can play a key role in helping those patients who might benefit from it to become engaged with, and to find the benefits that can come from this particular type of treatment. So just briefly to round off the idea of the global treatment models and cultural adaptation. The psychosocial strategies that we use, they need to really strike this balance between the universal principles and cultural specificity. And Freud and Jung, they both recognize this importance, the importance of cultural context in psychological practice. And the balance, I think, means that we need to acknowledge our shared humanity, and tailor the approaches where we can to the cultural context that we live in. The principles, for example, of peer support and family involvement are universal, but their implementation might look different in Turkey, say, compared to the US or the UK. But I think what's important to recognize is the principle itself, and not get lost in the details of implementation. So hopefully we've all learned something about psychosocial interventions, and what I think they are and why they're important, and 12-step facilitation therapy as an intervention that employs psychological and social elements to it, and then the social context in recovery, and this idea of global treatment models with cultural adaptation. And if anyone has any questions or comments, I would love to hear them, and thank you for listening.
Thank you so much, Peter.
Çok teşekkürler.
I
Çok
actually have
teşekkürler
one
Peter.
question for Kültegin Hoca and for you as well. But if anyone else might want to start first, maybe I can give the stage to them first. Benim birkaç sorum var ama belki konuklarımızdan ilk önce soruları alabiliriz diye düşündüm.
If there are no questions from our participants, I would like to ask a question. There is one question.
Yemek Bey'in bir sorusu var.
Harika.
Go ahead, please.
I'm gonna ask a question from Peter and tell him welcome and thank you for sharing this valuable information. Peter, I think we met last year in Moody's and we had a small conversation in the cafeteria, as I remember. And it's so nice to meet you again. And I want to ask, from the first day in your 4 weeks treatment program, the inpatient joined to the 12 steps group therapies or not? Because as you know, they are so sensitive to get any medication during joining to the program. So there is a contradiction between the medication and joining the 12 step. How do you fix that contradiction between two fields?
Yeah, thank you. And it's lovely to see you again too. And thank you for that question, because it can be, I mean, it's one of the issues that I struggled with most when I started working with this model, because previously I had worked in really a harm reduction approach type outpatient NHS treatment for, I mean, mostly methadone maintenance for opioid use disorder. And, I'd worked in a lot of inpatient, medical services where we, harm reduction and the use of, medications were life-saving for a lot of people, and are life-saving. So coming across this attitude in some 12-step groups that any medication is, anathema, any medication is, you can't be on it if you want to join the groups. So the first thing I'd say about treatment at Castle Craig, what we're not doing is running 12-step groups. We're not running AA groups in treatment, right? So it's different to that. Yes, if you do, if you go to an AA, or let's say you go to an NA meeting outside of Castle Craig and you tell people that you're on methadone, you might be asked to leave. You might be told you can't. I don't actually. I'll say, like, I don't go to those meetings myself, and so it's probably, actually, I don't want to give incorrect information there, but I do know that the general attitude can be, if you're on medication, you're not really doing it right. Again, at Castle Craig, when everyone comes in, they first come into an admissions unit, so they're separate from the rest of the patient population, and they, for anyone who needs a detox, then they'll get started on that in the admissions unit. But if they're stable, then they'll go the next day or the day after to join the rest of the community. And so we have a lot of patients who are midway through their detox. Let's say they're having a standard alcohol detox, which could take seven days or so, and they'll be going to groups and therapy and everything, and there's no problem with that at all. And all the patients are in the same boat overall. So everyone has a lot of understanding, I think. Does that help?
Sure. Thank you. Thank you, Peter.
Mader Hanım.
Thank you so much
Miss Nada.
for your sharing, Peter and dear Kültegin Hocam. Can I ask a question about planning the case in I would like to ask for clarity, is case planning done for each patient with a supervisor from the Craig?
I'm sorry, the sound cut out there for a second, so I missed part of that.
Just a second. Now she will ask again.
I'm saying again, is the case planning done for each patient with a supervisor therapist in Castle Craig?
So does each patient who's seen by a therapist have a supervisor? Was that the question? Yes, yeah. So the therapist kind of staffing structure is such that we have junior therapists, senior therapists, specialist therapists, and then a unit lead who's had a decade or more of experience, and each therapist has supervision from either the unit lead or deputy unit lead, and then they have that direct supervision throughout the week from the senior therapist, and then they have weekly supervision in a sense, although I call it a multidisciplinary team ward round. So once a week I'll meet with all of them and we'll talk through, initially we'll talk through every new patient who's come in from the week before and go through in detail their assessment and plan. And then we'll talk through any patients who are struggling, where issues have come up in therapy or the community. And so they'll have that supervision from myself and again, and from the whole team with all the senior therapists there. So yeah.
Thank you so much.
Şu an için yok galiba başka soru. Ayşe Hanım sizin vardı. Kültegin hocamıza bir sorunuz.
Evet,
No more questions from the participants. Ayşe Hanım, you have a question to Kültegin Ögel.
kapatıyorum bir saniye. Çeviriyi kapatayım. Evet. Şöyle ben en çok relapse index hakkında merak ediyordum. Yani bu relapse indeksi yaptıktan sonra Kültegin hocam bu bilgiyle tekrardan bir plan mı hazırlıyorsunuz outpatient ayaktan tedaviler için, yoksa sadece bakıyorsunuz nasıl ilerliyor bu kişi, bu hasta. Yani bu relapse index'in skorlarıyla ne yaptığınızı merak ettim aslında. Diğer bir sorum da şimdi psikososyal destekten bahsediyoruz ama hani psikolojik çalışmalarda gösteriyor ki böyle bir destek istenildiğinde en iyi sonucu veriyor. Tedaviye birisi için gelmiş, resistant olan bir hasta ya nasıl support sağlıyorsunuz? Biraz onu sormak istiyorum. Yani kişi kendi isteğiyle değil de mesela ailenin isteğiyle yattıysa bu support'u verirken nasıl tailor ediyorsunuz bunu o kişi için?
İkinci sorudan başlayayım.
Hı hı.
Aslında ikinci sorunun cevabı motivasyonel görüşme. Bütün ekibi de biz zaten motivasyonel görüşme eğitimini alıyoruz bir şekilde. Ama her hastaya motivasyon kazandırma şansınız da yok. Çünkü değişim zamanla olacak, motivasyon da zamanla kazanılacak. O zaman her zaman da bu motivasyonu sağlamak çok mümkün olmuyor. İlk soruya gelecek olursak aslında ilk hedefimiz bizim bu mori yaptıktan sonra danışanla paylaşmak. Yani kendi görmesini sağlamak. Bilmiyorum diğer popülasyonlar nasıl var? Türkiye'deki popülasyonda genelde tamam ben yattım çıktım bitti bu iş. Ya da işte kafamda bitirdim. Artık bir daha içmem. Halbuki biz bunu kullanarak nerelerde risklerin daha yüksek. Bunu öncelikle onu anlatmak. Tabii ki o sırada terapist de şunu görüyor. Ben bundan sonra çıktıktan sonra neyin üstüne çalışacağım? Daha çok neye ağırlık vermem lazım? Tabii beklenmedik şeyler de olur. Ya da zaten gündemimizde olan, ajandamızda olan program da uygulanabilir. Ama bence buradaki en önemli şey aslında bir feedback olarak danışana vermek ve onun bunun farkına varmasını sağlamak.
Teşekkürler cevabınız için.
Başka sorusu olan, katkısı, yorumu, görüşü olan varsa alabiliriz bitirmeden önce. Ceyda Hanım buyurun.
Benim McCann'e bir sorum olacaktı. Ama if I understood correctly, 12-stage facilitation therapy is central
Eğer doğru anladıysam 12 basamaklı kolaylaştırma terapisi merkezi bir yer oynuyor. Bizim tesisimizle karşılaştırdığımızda bizde bireysel seanslar,
etc., which are kind of supplementary to the individual sessions. And I think you said there are individual sessions twice a week, right?
Yeah. Yes.
I wonder if, I mean, do individual sessions increase when that's necessary? Because if you want to assess the psychological things, you said that you have the test for that and you have the assessment thingies, but I didn't understand. I mean, I understand that, but when I compare it to our facility, it's a bit, I don't know.
Yeah, I think I understand what you're
Yeah.
saying. Yeah, I think I understand what you're saying. If I understand you correctly, you can see how it could be challenging for someone who has, say, who's having a depressive episode or has PTSD. PTSD is a good example, I think. So how would 2 sessions a week of mostly 12-step focus work be enough? How would you fit in PTSD? How would you fit in basic grounding skills, an initial trauma assessment, and then maybe EMDR or something? So the twice a week sessions are meant to be focused on 12-step work, and then we build in additional sessions for patients who need them. And we, with PTSD, for example, you need to be careful when you're starting trauma therapy in someone who's only going to be somewhere for 4 weeks, and making sure you're not opening up something that you're then going to let the patient go off into the world in a vulnerable state. So often, the initial assessment and the plan for someone who's only there for 4 weeks, it might just be as much as saying, look, we think you have PTSD, you're having active symptoms that could be impacting on your addiction. We can start some initial grounding work, but we're also going to recommend that once you leave, you continue some kind of psychological therapy for PTSD alongside your ongoing 12-step work, and then help the patient where we can to find a therapist to do that. If that's with us, great. If not, then helping the patient find that additional therapy that they need. And the same applies for CBT, patients who need CBT for anxiety disorders, mood disorder, whatever it is that we think they need the help with while they're with us, then we find ways to, so either the focal therapist, if they have that training, can work with them on that, or they can see one of the other therapists alongside their so they could have kind of two therapists, right? Does that answer your question?
Yeah, so you tackle the comorbid situations and some other needs, maybe some patients need for I don't know, more psychoeducation stuff. Then you increase the number of the sessions during the hospitalization and also after the discharge, I guess. Do I
Yes.
understand correctly? Okay,
Yeah.
thank you.
Where possible, of course. You know, and yeah. I was wondering, Professor Ögel, if I could see the relapse the relapse tool that you have at some point. Maybe try and translate it, and I'm very interested in, you know, in seeing if that's something that would be useful to introduce for our patients, and yeah, I wonder if there are even other applications for it, like Ayşe was suggesting, along the lines of, you know, how many, the intensity of outpatient sessions you have, or additional supports for people in higher risk categories. So yeah, if it's available, I'd love to have a look at it at some point. Oh,
Hocam sesiniz açık değil.
Tabii ki RAPS
Of
indeksini
course.
size çevirip gönderebiliriz. Diğer
I
sorunuza
can
da-
send you our index. Yeah, of course, that we can translate it and send to you. Also the
Bu
other
arada ben
tools.
düzenlediğiniz için bu toplantıyı da hem Ayşe Nur'a hem de
I would also like to
Zülküf'e
thank
teşekkür
Ayşe Nur
ediyorum
and
ve tabii,
Zülküf for organizing
Jamie
this
ve
event.
Petra'da.
Also to Jamie and Peter. Thank you.
Biz de katılımlarınız için çok teşekkür
And
ederiz
we would like
Kültegin
to thank you
Hocam,
for your
Dr.
participation.
Peter ve bütün
Professor Ögel,
katılımcılarımıza da
Dr.
teşekkür
Peter,
ederim.
Jamie, and all of our participants. Thank you so
Çok
much.
teşekkür ederiz. Umarım tekrar yeni bir oturumda, yeni bir
Thank you. Hope to
seminerde
see you
görüşürüz. Çok selamlar.
again in a new seminar.
Londra'daki ağırlamanız için de teşekkür ediyoruz.
And we would like to
İletişiminiz
thank
için
you
de.
for hosting us in
Yeniden
London, for your
diğer vakitlerinde görüşmek
communication.
üzere.
Hopefully we'll be seeing each other again. Goodbye.
Thank you, everyone. Lovely
Thank
to meet
you.
you.
Thank you, everyone.
Bye.